So let's just say that they get gemdosi and they recur. Now you're making a decision on, how does my large urology group practice in Nashville flesh out our portfolio? So let's call it, BCG, unresponsive, gemdosi, refractory, not getting a cystectomy because either you don't think they need it or they're not fit. So what do you have available?
How do you order all this stuff? Yeah, so I've used a lot of Adstiladrin. What's really nice with Adstiladrin is patients almost feel like they're getting a break because of the quarterly dosing, right?
Let me actually back up. Let me back up a second, Tom. So you're sitting there in practice, obviously kind of keeping up with things. How do you make the decision on what I'm going to pursue next? Are you going to the SUO? Are you going to the AUA? Are you, you're talking to your buddies at Vandy? Like, what happens?
Well, I mean, so one of the nice things about being really involved in clinical trials is I'm myself, I go to a lot of meetings. I talk to a lot of folks, like I said, I'm kind of fortunate to wear this hat of doing a lot of research. So, I'm pretty involved in a lot of this stuff. So yeah, so that's part of it, is just going to the meetings and talking to folks, but also because I do so much bladder cancer, as you know, you just kind of live it. You just kind of live this world, and you have anecdotal experience, which becomes significant after a while. But you're right. The average urologist, I think, who doesn't do a lot of this, it goes back to this notion of how do those people keep up, right? And I think the simple answer is you don't. You refer it out to somebody who does a lot more than you do, and that's probably the easiest way to do it.
So you're living in this world, and it sounds like you have experience with Adstiladrin. Walk us through a little bit, just so you decide, you see the data, you're like, okay, this is compelling. I've looked at the, complete response rates, progression-free rates, cystectomy-free rates, and you've decided that, all right, gang, this is the one that I think is the right next step, fastest horse as it stands. Can you walk us through a little bit about the process at your institution to operationalize this?
It's been easier than we thought. We have an oncology RN who I basically send a message to. I talk to the patient about the drug, and she coordinates with our admin about buying it and storing it. Again, one of the big defining things about all of these drugs as they come out, to me, is going to be the logistics, storage and handling, cost, some of the corporate policies about, making groups whole if a patient doesn't show up. In the community, that's going to be the biggest thing. My opinion is that the CR rates, like I said, are all going to be comparable. And you really shouldn't be comparing them, because we talked about certain trials have reinduction, certain trials don't. Certain trials have mandatory 12-month biopsies, certain trials don't. So the CR numbers are fine, but they're definitely not a perfect indicator of how each drug is going to compare against another. So yeah, like I said, it's been pretty straightforward with nadofaragene. We put the order in, and the drug gets ordered, and our oncology nurse administers it. It's, again, quick. The patient stays for a fairly quick amount of time. And again, the big benefit that I've seen is that patients feel like they're getting a break, because they're used to weekly BCGs. They're used to a ton of interventions and treatments. And now you're saying, okay, we'll back down. I've liked that.
Yeah, so just a couple of comments. That's kind of our first one that we had on formulary. We've got some of the newer ones coming through the pipeline, working to get those on formulary. So Adstiladrin is the medication I also have the most familiarity with. Access support, it's good. We kind of learned the hard way, actually. One of the dudes showed up, and they were like, oh, yeah, it's going to be like $20K. And he's like, yeah, well, I'm not doing that. And our institution wanted to do all the pre-auth, et cetera, in-house. And then, shocker, shortly after that experience, we leaned on the access support outfit. So basically you submit a form with the clinicals, and they're like, yep, it's approved. They kind of work with insurance, and it takes it off the plate. And we've got a whole mechanism too where the patient's contacted. The storing and handling wasn't as offensive as I thought it would be. We brought on Jayram. That was a bit more involved, but we're happy to have it. And we touch base with them. We get a UA usually at least about a week prior with the reflex culture. We don't want to discard the drug. And thankfully, there's a pretty good process in place. Like if you were to have an issue, they they had a spasm and they leaked out the drug, God forbid. That's a pretty expensive micturition. So there's some kind of tips and tricks in there, but I have found that the customer support, patient support has been quite good. And honestly, when I first learned about the drug, the every 3-month dosing, I was like, whatever, it's between saving your bladder or not. Who cares if you're getting 6 or 1? But I would agree. The patients kind of like it. And for our folks that are coming in from, the Central California or Western Nevada, I think some of the access things, like I'm sure for you guys, you mentioned, Southern Kentucky, Northern Alabama, that might be kind of nice. So it sounds like that's your kind of next go-to. And then what comes after that?
Yeah. I mean, it's a discussion. We used a lot of Pembro early on. We were one of the early adopters, early groups of operationalizing in-house Pembro in a big urology clinic. And we've been fortunate now that experience is starting, amongst big urology groups. We've got some survey data that about 20 to 30% of big urology groups are giving Pembro in-house. And we have some resources. There was an AUA update that we wrote about managing side effects. There was a couple courses we gave the AUA. So there's a lot of interest and enthusiasm and I think know-how now on how urologists can give IO therapy. So I don't think that's a huge barrier, but honestly, I think this too, the data just isn't that great, and anecdotally, it just hasn't worked as well. I just haven't been as thrilled about it, and I think probably the role of IO in bladder cancer is going to be in combination therapy in non-muscle invasive bladder cancer. I don't think monotherapy is going to be a home run. But so, Pembro is still an option, especially if patients are really bothered, their bladders are beaten up, they're, have a lot of irritative voiding symptoms. Pembro is a nice option because it does provide them with, a non-catheter based alternative, although you have to deal with the systemic side effects, which, again, as I mentioned, I think are pretty manageable in the right patient. And then, so then for us, it comes down to a clinical trial. Anktiva is very new and very exciting, but it's still very new. And they're kind of going through with what Adstiladrin went through a year ago, right? With getting their average sales price tabulated, with getting universal coverage, with getting a J code, with getting Medicare pass-through status. So all that stuff will take time. And, Anktiva is certainly something that I think could be the next step, just like Pembro. But probably in our practice, we'd move them towards a clinical trial.